Hello, ladies and gentlemen, friends from all over the world. Welcome to this PCR webinar performed with the unrestricted grant of Medtronic, dedicated to the treatment of a patient with in-stent restenosis. This is a webinar that we plan to do mostly very practical, based on the discussions of real cases with long-term follow-up and a recorded case in the cath lab of Newcastle upon Tyne. This wants to give you hints on the diagnosis, the classification, and the vessel preparation for using the technology offered by the drug coating balloon therapy and the analysis of the immediate and the long-term results. The rationale behind this technology for treating in-stent restenosis, and go straight to the issue of the clinical application and all the scientific evidence that has been built on this field. To do this, which is quite an ambitious program today, it's my pleasure to work together with Professor Bruno Scheller, who is an interventional cardiologist at the University of Saarland in Hamburg, Germany. Welcome, Bruno. Thank you for being here with us. Professor Atfad Zaman from the cardiology of Newcastle upon Tyne, the last city in the north of England, but before the Adriano Wall. And myself, I am Flavio Ribichini. I am the chairman of the cardiovascular division of the University Hospitals in Verona, in Italy. So after this presentation, I hope you will be interested on following our work, and I will start again with a very practical vision of what we are going to do today. In-stent restenosis does exist. The dream of restenosis zero was not true, obviously, after the first experience with drug-eluting stents. And as you can see from different statistics coming from Europe, it represents nearly 5% of our percutaneous coronary interventions. In the US, in this registry that has been published recently, shows that the number of patients and the percentage of patients being treated in the US because of in-stent restenosis is a bit higher than in Europe. So with no further delay, after this introduction, I will hand the control to Professor Scheller to start talking in depth about the issue of in-stent restenosis after we see a case, because as I said, this will be a very practical session. Can we have the first slide, please? This is a case performed in my center. It's a long story that I will make short, because the most important of it is the evolution of the treatment that these patients was exposed to. As you can see, it's a young male born in the 64, first time on a cath lab in 2011, when he was treated for a disease of two vessels complaining for stable angina. So the right coronary artery, as you can see, is normal. And this is his problem. There is a focal stenosis on the proximal LAD and a focal stenosis on a small circumflex. At that time, don't ask me why, he received two bare metal stents, a 3.518 into proximal LAD, which was deemed to be a very big and nice vessel. So probably the idea was that DES was not necessary, and a smaller bare metal stent in the circumflex with a good angiographic result. But after only 6 months, he had again stable angina, so he came back for a second procedure. So you can see the right coronary artery is dominant and normal, and here it is, a diffuse subocclusive restenosis of the small stent in the circ and a focal tight stenosis on the big LAD. Another operator took care of this patient. At this time, the everolimus eluting stent was very on fashion, with the strongest evidence of safety and efficacy, and that was the choice at that time. First in-stent with a prime Xience prime 2.523 on the marginal with a good immediate result, and Xience 3.523 in the proximal LAD, again with a very nice immediate result. So at that point, I think that anyone would have thought that the problem was solved for a long time. However, despite this nice angiographic result, the patient came back 8 months later with recurrence of stable angina again. So this is his third time on the table. The right coronary artery remains normal. And this third intervention was performed by myself. I have to admit that I am a believer on drug-eluting balloons. And so what I did, which was also the last option, was treating the patient with, at that time, the Falcon drug-eluting balloon, 2.53 millimeters in the oblique marginal. And as you can see, the angiographic result is very nice. And then same treatment on this focal in-stent restenosis on the proximal LAD. Here it is, a Falcon balloon 3.520 millimeters with a very nice immediate result. So I had to tell you that the patient was known to our division because of a bicuspid aorta. And after 9 years, he came regularly for the controls of the aorta without suffering angina any longer, until the aortic stenosis became symptomatic and severe, as you can see from his echocardiogram performed early this spring with a peak gradient of 85 and a mean gradient of 46. So he was advised a surgical replacement of the aortic valve, and the surgeon asked to have an angiographic check. And this is what I'm going to show you. The right coronary artery is stable without disease, but most interesting, the left coronary system totally healed after 9 years of follow-up. At this time, just for curiosity, I did what perhaps we should have done before, an IVUS. And the IVUS shows in the lower part, you see this is the circ, which is a little bit underexpanded, but it's totally clean with no signs of regrowth of neointima. And this explains the good long-term result, while the LAD that you see in the upper panel shows clearly, again, the stent being clean. Actually, you see the double layers of stents in the two vessels. And at a certain point here exactly, an under-expansion due to the 360 degrees calcification. But despite that, the patient did not have angina any longer, thanks to the long-term efficacy of the DCB therapy, and underwent aortic valve replacement. So, Bruno, I hand it to you to explain us the mechanism, the classifications, and the clinical implications and predictors of in-stent restenosis.
Yeah, dear Flavio, dear Asfa, dear ladies and gentlemen, it's a great pleasure. You know, when we are talking about in-stent restenosis, we are talking about different clinical presentations and different angiographic presentations. And therefore, one of the first classifications looked at the patterns of in-stent restenosis angiographically. And the decision was, do we see a focal or a diffuse or proliferative in-stent restenosis? Meanwhile, we learned that not every in-stent restenosis has the same underlying mechanism, and therefore newer classifications are dealing with the reasons why we have a restenotic stent, mechanical reasons, biological reasons, or mixed reasons for these findings. When we go back to the histological examinations, for example, here for bare metal stents, we learned that the amount of injury you create is one of the reasons why we have neointimal formation, which is in contrast to our goal to have no stent under expansion. And we know that we can create inflammation by this permanent implant, and these are the factors leading to restenosis. For drug-eluting stents, we have much more knowledge meanwhile, and several factors have been identified as risk factors for restenosis after drug-eluting stents. And the main predictors are the total stent length. This means the more stents we implant, the higher risk for restenosis we have. And very interesting for the drug application is the fact that the maximum distance between the struts plays a role. This means the more the difference between the struts is, the lower the drug amount in the area between the struts may be, and this is another factor contributing to restenosis. Meanwhile, we learned that we have additional factors, especially over the long term, which could contribute to the development of restenosis. One is stent fracture due to mechanical stress for the stent over longer periods of time. And more relevant becomes the topic of neoarteriosclerosis, which occurs earlier after drug-eluting stents than after bimetal stents, and much more frequent after drug-eluting stents than after bimetal stents. And neoarteriosclerosis can result in thrombotic events or in in-stent restenosis. So this elegant analysis looks at the time course of clinical presentation of in-stent restenosis. And as you can see, stent underexpansion is a factor that plays a role, a dominant role in the first year, whereas neo-intimal hyperplasia gains more and more relevant over the time after the first year. Another big topic, meanwhile, is the treatment of bifurcations. As you know, the European Bifurcation Club recommends the use of a two-stent strategy in most cases. And we had to learn that especially this strategy results in increased thrombotic and restenotic risk. So this means the more complex lesions we treat, the more stents we use, the higher risk we have for in-stent restenosis. And therefore, the current European guidelines on revascularization recommend first the assessment of stent failure. What is the underlying mechanism? And as you can see, with all these new imaging modalities we can very well define the underlying mechanism. So my conclusion from this first presentation is that in-stent restenosis decreased over time from bimetal stents to the first generation of drug-eluting stents to current generation drug-eluting stents. However, as Flavio showed in the beginning, ISR is still of clinical relevance in the range between 5 to 10% of all of our PCI procedures. DAS ISR is multifactorial. We have biological reasons like injury, inflammation, neoarteriosclerosis. We have device-related reasons like stent fracture, the interstrut distance, and coating technology-related reasons. And there are also procedural-related factors, stent length, stent diameter, bifurcations, two-stent strategy, malapposition, or underexpansion. So the precondition of any ISR therapy is to identify the underlying mechanism, and this is also the case for additional imaging. Thank you.
Thank you, Bruno. I forgot telling you, but I see that our participants are very familiar with this system of questions because they are frequent users of the PCR online. So please make your questions. We have several already. Bruno, so you said the longer the stents, the more you put, the bifurcations, the smaller they are, the higher the risk of restenosis. That's very important. In the case I've shown, we had diffuse proliferative in-stent restenosis in the small circ and focal restenosis in the big LAD. Is that true? I mean, big vessels do have more focal restenosis and small vessels do have more diffuse, or this is unpredictable?
I think you have both in both sizes, but it's more, as you say, you have more diffuse restenotic lesions in smaller vessels. A big vessel with a short stent, it's very rare that you have other than focal restenosis.
So it would make sense to try to avoid stents in small vessels and try to use drug-eluting balloons also in native small vessels. Does it make sense?
Of course, I fully agree. It's not a topic of this webinar, of course, but you're right.
The next, but we see how small vessels are prone to restenosis. So we move to another case while we will try to address other questions. The second case is again a case of what you are talking about, long stented segments and long-term follow-up. Again, a young male performed somewhere in 2006. I don't remember where. At that time, Cypher was the stent, and he got 3 on the proximal LAT and 1 on the right. He did very well for 7 years, confirming how effective these stents were. But in January 2013, he came to my observation because of abrupt recurrence of stable angina. And what you see already is clear. The Cypher on the right is okay. There is collateral circulation on the LAT, which is totally occluded from the ostium. And you can see this long stented tract from the proximal to the distal LAT. To start with, I did perform the IVUS, and the IVUS confirmed that the stents were quite well opposed. But there is a lot of material inside the vessel lumen, which is either neointimal hyperplasia or thrombus. I did the angiogram just to check that the anterior wall was still moving, and indeed it was. So I continued with hydrophilic wire that easily went through, confirming that it was mostly thrombus and a soft neointima, and dilated both the LAT and the diagonal. The diagonal didn't want to stay open, so I did implant a new stent that was a Xience stent on the diagonal, and this is the immediate result. I checked the IVUS to make sure that the stent was clean and all this material in somewhere went, either was smashed or embolized, but the flow was okay and the patient was discharged. But 6 to 7 months later, after a brief period of well-being, he comes back with the same angina in July 2013. Again, the good old Cypher in the right is doing his job, but as you see, collaterals again on the LAT, and this time, even the new stent, the Xience in the diagonal, is diffusely restenosed and the LAD is occluded again. So this time, what I did was again checking this is a brutal test, I agree, but it's on the table, the LV function was preserved, the anterior wall was just hypokinetic, and this time it's an extensive treatment with the release of paclitaxel with the old impact Falcon in all the distal and mid LAD, and also in the diagonal going through the wires of the stents on the LAD and treating the in-stent restenosis of the site of the Xience and the proximal LAD. The patient was discharged. I want you to have a look at this angiographic aspect, which is far away from being ideal. You see this residual stenosis in the distal LAD, this aspect of dissection, a tight lesion on the proximal part of the diagonal, but with good flow. And in this image, probably a clear dissection of all the proximal part of the diagonal. Despite that, the patient was discharged. He did very well. And after 1 year, I asked him to come back for an angiographic follow-up. And this is elective. The patient had this result, which looks actually much better than what I left 1 year before from different incidences. Okay? But the most interesting thing of this case is that the patient, of course, normalized his LV function. This was not difficult to forecast. But the most interesting thing is that we called this patient this summer after 8 years of the DCB treatment, and he's doing perfectly well. So this is what we want to talk now. It's about the long-term efficacy of this therapy and to work on how to treat in-stent restenosis. I will handle the next part of the presentation to Professor Zaman.
Thank you, Flavio. Thank you for the invitation. So Two great cases, and what they show is not only focal and diffuse stenosis, but they also show us that the timing is unpredictable. Sometimes you can get ISR immediately. Sometimes, as we've seen and you'll see later on, it can develop over several years. So how to treat ISR? So the first thing in terms of education is to understand what the ESC recommendations are for in-stent restenosis. So the ESC recommends either a drug-eluting stent or a drug-coated balloon. And they can be used either if the original stent was a bare metal stent or indeed was a drug-eluting stent. In patients that have recurrent episodes of diffuse in-stent restenosis, and where successive attempts at treating has failed, then of course coronary artery bypass grafting should be considered. But of course you are then dependent on there being an area for the grafts to be planted. But you saw in the previous case of Flavio's that sometimes if you give a different drug, in that case paclitaxel, that patients may respond where they had an Olimus drug beforehand. The one thing that I do want to point out and emphasize what Bruno said is that imaging is mandatory if you're going to define the mechanism of the in-stent restenosis. So in summary, either drug-coated balloon or drug-eluting stents both have a 1A recommendation, and you'll see later in the live case that we have this dilemma of which to use, and we can discuss that later. Imaging is mandatory. Of course, it's stating the obvious, but a drug-coated balloon avoids an additional metal layer. The one thing that is a take-home message from today is that if you go on to use a drug-coated balloon in any scenario, whether it's for in-stent restenosis or whether it's for de novo lesions, lesion preparation is essential, and this lesion preparation should be with a high pressure and or scoring balloon, and you should try to achieve an optimal preparation before drug delivery, which is to achieve a plaque area of less than 60%. It goes without saying that if imaging is mandatory, it is because angiography alone cannot identify mechanisms of in-stent restenosis. You can use either IVUS or OCT. OCT, with its higher resolution, may be superior for distinguishing the disease process, particularly for characterizing the tissue type, and we'll see images of this following this slide. It is important, as Bruno has emphasized, to identify the mechanical from a biologic cause. These are the common images that you see, and these are magnified images of the previous images that you've seen. And what I want to emphasize is the difference between neointimal hyperplasia on intravascular imaging from neoatherosclerosis. So in this slide, where you have neointimal hyperplasia, what you see is a homogeneous, bright, uniform layer on the IVUS to your left, and a homogeneous layer in the IVUS to the right. You can see clearly the stent struts are clearer to see on the OCT, and you can just about make it out on the IVUS. For the neoatherosclerosis, you can see that it is a non-homogeneous. You see these areas here with the red arrow. The non-homogeneous layers shows lipid-rich layers, which are typical of neoatherosclerosis. And these are two very good examples of understanding the mechanism of in-stent restenosis. We all recognize that stent underexpansion promotes in-stent restenosis. And you can see here this cross-section with underexpanded stents seen both in the IVUS to the left and to the OCT to the right. So you can see the mechanism and you can see the cause in these examples. There have been several studies now that have compared plain old balloon angioplasty in ISR with BMS stents. So there have been the PEPCAD studies, the PACOCAF studies. There have been a comparison of drug-eluting stents, the paclitaxel types in BMS ISR. There have been the SEDUCE studies, the RIBS-5 studies, which have looked at comparing Olimus stents in BMS ISR. And more latterly, there has been a meta-analysis of DES taxa stents versus a drug-coated balloon with the paclitaxel versus plain old balloon angioplasty. And all of these studies show the efficacy equivalent to that of drug-eluting stents in patients with ISR. The added advantage, of course, is that if you use a drug-coated balloon, you can limit the duration of dual antiplatelet therapy in these patients. So in summary, for in-stent restenosis following a bare metal stent or drug-eluting stent, you have the choice of using either a drug-coated balloon or a drug-eluting stent. Imaging allows identification of the mechanism, which then subsequently guides strategy. If you choose to use a drug-coated balloon, please remember that lesion preparation guided by imaging is essential. And remember also that the drug-coated balloon is for drug delivery only. You have to prepare the lesion adequately beforehand.
Thank you. Thank you very much. As far, very clear, very useful. So summarizing as I did before, guidelines clearly recommend strongly, it's a 2A indication to interrogate with intravascular imaging when something went wrong with the stent. It's not frequent, but it happens. Then it provides you information on the mechanism. You said mechanical, which is under expansion or fracture or not well opposed, or biologically, which is tissue growth, whether it is thrombus, neointima, or neoatherosclerosis at the long term. And again, the choice of the treatment should be guided by this. So we are providing very useful and important advices to our colleagues. I am really pleased to say, and I'm not cheating, there are a lot of questions so far after 30 minutes or less of our presentation. So I will propose you a ping pong ask and question. You are super experts, so no more than 10 seconds to give an answer. As far, you talk about imaging. Is the incidence of in-stent restenosis reduced by using PCI guided by imaging?
So in instances of underexpansion, imaging will make sure that you don't underexpand, and therefore the likelihood is that you will reduce in-stent restenosis due to that mechanism. I have no data at the moment, but if that is the mechanism, then you will reduce it and you will reduce in-stent restenosis. Good.
Bruno, another interesting question. The Falcon balloon contains paclitaxel, and some of the stents you have shown contain everolimus. Does this mixed make a difference?
No. The point is that paclitaxel and limus agents have different targets in the cell. So if you block the cell cycle by limus, you have no additional blockage by paclitaxel and vice versa. So therefore, you can combine it, and we have also some safety data in the preclinical model and also from patient registry.
It's safe to mix the drugs. Is it safe? You would advise people not to worry about mixing the drugs.
No, it's safe.
Correct. Again to Bruno, how much is neoatherosclerosis responsible for in-stent restenosis?
Within the first year, it's not that a problem. But if you have restenosis at 5 years or 6 years, 10 years, then neoatherosclerosis plays the predominant role.
And this is my question: is it more dangerous, neoatherosclerosis, than neointimal hyperplasia? Is more prone to evolve in acute coronary syndromes?
Yes, because you have also plaque ruptures with neoatherosclerosis, which is not the case with neointimal hyperplasia.
Great. As far a colleague asked, does oral sirolimus represents an alternative for treatment of anti-restenosis or not?
Yes, absolutely. The problem with sirolimus has always been its stability on a balloon platform. But with nanotechnology, we are seeing new products coming along with sirolimus on balloons. and they are in the phase of being assessed to see if they are as effective as the Taxol-eluting balloons.
Okay, Bruno, 5 seconds for this answer. Very practical. Should we choose a balloon, a drug-coating balloon with a 1-to-1 balloon to vessel ratio, bigger or smaller?
Yes, 1-to-1.
1-to-1. Great. I'm happy that we have provided answers to most of the questions, not all of them. And now we move to Bruno. Please, Bruno, update us on a little part of the history, how it came to your idea. You are a pioneer in that, on using drugs, and what is new in the scientific field. Okay,
thank you, Flavio. A little bit back in history, when we had the first animal data with drug-coated balloon, we discussed how to conduct the first in-man trial. And at this time, this was in the year 2002, 2003, drug-eluting stents were not yet available for clinical practice. And we had this issue with bare metal stent in-stent restenosis at this time. And bare metal stent restenosis was the perfect target for such a first-in-man trial because it was the indication which is safe because there's already a stent in there. You have neo-intimal proliferation, which is more dominant with BMS than with DES. So this means if we have a too high drug effect for this first-in-man trial, we are on the safe side because there is lots of tissue already there. On the other hand, to show efficacy of a new device, it's better to have a clinical scenario with a high event rate because then it's easier to demonstrate that it works. And this was also the case with bare metal stent restenosis. And so we designed this PACOT ISR1 trial in bare metal stent restenosis. And that was the reason why we started with this, and not small coronary arteries. Meanwhile, we have much more evidence for different treatment strategies for in-stent restenosis. And this is one of the elegant meta-analysis we have seen in the past. And this shows you that compared to uncoated concepts, drug-coated balloons and drug-eluting stents are the two treatment options for in-stent restenosis that gives you the most reduction in repeated target lesion reinterventions. For drug-coated balloons, we have several randomized trials available, and this is a very elegant patient-level meta-analysis, the Daedalus study, including 10 randomized trials comparing DCB with the stent-in-stent approach for drug-eluting stent restenosis. And as you can see, both treatment options have their advantages and disadvantages. For example, we see a somewhat higher rate of target lesion revascularization for the DCB use compared to the stent-in-stent approach. On the other hand, if you look at hard endpoints like death or myocardial infarction, there is not a significant difference at 3 years, but the numbers, event rates for DCB versus stent-in-stent are lower. So I think we have arguments for both treatment concepts in in-stent restenosis. One interesting thing, if you look at this data, is what draws, for example, this difference in target lesion revascularization, which was in favor of the stent-in-stent approach. This was the RIPS4 trial, which predominantly caused this result. And if you look at the relation between TLR and restenosis, then you can see that more restenotic lesions in the DCB arm were treated again than in the stent arm. So this means if you do not implant additional layers of metal, you have more options for the future for repeated intervention. So maybe this disadvantage is in real life an advantage for these DCB concepts. What then can we do to improve the angiographic outcomes, reduction of TLR? This is elegant work from Antonio Colombo's group, where they looked on the result of lesion preparation. If you fulfill the consensus group criteria for an adequate or acceptable result, which is a TIMI-3 flow, a residual stenosis of less than 30% and no major dissections, then you have a significantly lower rate of TLR than it is the case if you do not fulfill this criteria. So other analysis supporting this data, finally, that the result of your lesion preparation determines the efficacy of the DCB treatment. What else can we do? We can use specialty balloons. This is the ESA Desire 4 trial. They randomized conventional balloon angioplasty with scoring balloon before DCB use in in-stent restenosis. And as you can see, there was a significant improvement of the angiographic outcomes when using scoring balloon instead of a conventional balloon. What is the recommendation? How should we treat ISR lesions and de novo lesions with drug-coated balloons? The most important step of the procedure is not putting the balloon there, it is the lesion preparation. And you should do this as good as you can and as aggressive you can to identify those lesions that can be well prepared and need only DCB treatment, and those lesions that require stenting with its additional radial strength and so on. And if you follow this concept of first lesion preparation and then decide what you do, then we have, meanwhile, very good data from randomized trials, from de novo and ISR treatment that show that you can reduce the risk of myocardial infarction within the first year. And maybe at longer follow-up, the stentless treatment may give you some advantages in long-term survival. The proposed strategy for ISR is first define the underlying mechanism of in-stent restenosis, for example, with additional imaging, treat the underlying mechanism if possible, for example, stent under expansion. And then when you have done all the lesion preparation steps, then you have to decide if you fulfill the criteria, no relevant dissection, diameter stenosis maximum 30%, then you can use the DCB for local drug delivery. Otherwise, you should stent it with a current generation drug-coated stent. So DCB for ISR have the advantage that there is no additional layer of metal. We can shorten dual antiplatelet therapy. It's easier to repeat the procedure than after stent in stent. And this may lead potentially to improved long-term outcomes. But we have to be aware that we have a disadvantage in the angiographic outcomes when not having another stent. And therefore, lesion preparation is essential in this treatment strategy.
Great. Thank you very much. So again, summarizing, this Daedalus publication in the European Heart Journal shows that there is not big difference between putting a drug-eluting stent or a drug-coating balloon. If you use drug-eluting stents, you have less recurrence of angina. If you put more stents and use instead of drug-eluting balloons, you may have more myocardial infarction. The concept is that you do not recage the vessel, and using a drug-coating balloon gives you more opportunity of treatment at the long term. This is great information. Another very important issue is that the biological response to the foreign body that it's a stent, it's a little bit unpredictable. So we don't know who will develop in-stent restenosis because of biological reason, but we do know that mechanical problems are linked to inadequate vessel preparation and stent expansion. So always, regardless your choice, prepare the vessel properly. And to go back to the previous presentation from Asfar and the question from the colleague, probably intravascular assisted PCI reduces this risk of missing the target of a good vessel preparation. Great. We are perfectly on time. We had a lot of questions very quickly. Asfar, what do you prefer to detect stent fracture, OCT, IVUS, or stent burst?
I think OCT with its higher resolution is much more likely to reveal stent fracture.
Okay, great. Bruno, a colleague asked whether you have in your practice long-term results that as the two I showed at the long-term with DCB. Is that, I mean, he wants to know if what I showed is just occasionally, or if with your experience you have also these long-term good results.
So in our clinical practice, we prep every lesion first and then decide what to do. And we have a DCB to stent ratio per lesion, not per patient, per lesion, of about 1:1. And we are practicing this since more than 10 years. So we have thousands of patients meanwhile. I can give you one example. For us, it has become difficult to include patients in in-stent restenosis trial because it's a really rare event. Because the number of stents we implant is low, and especially the length of the stents we implant on average is relatively low, and this gives you a low number of in-stent restenosis cases.
Okay. Drug-eluting balloon treatment of native vessels, de novo lesions, small vessels, and long lesion will be a topic of a second webinar. But we mentioned that it could be a good indication for small vessels. As far how small should a vessel be to consider DCB instead of stents? Below 3, below 10?
Yeah, the current evidence, and Bruno will be aware of, the bulk of the evidence is for vessels 2.75 and less. I think as the drug-coated balloon evidence moves forward, it's now got to look at the 2.75 and above. But the current evidence would support use in 275 millimeters and below diameter.
Okay. Last and very quickly, because we risk to run late, but I have too many questions, and this is what I like to go back to our colleagues. Bruno, can we identify patients with in-stent restenosis that could be better treated with either another stent or with DCB?
I personally not. For me, it's always the decision depends on the result of the lesion preparation. So if you manage to have an acceptable result, diameter stenosis of less than 30%, no floor-limiting dissection, for me, DCB is the first choice. Otherwise, DS is the first choice.
Thank you. So now we move to the show of our live case, which is actually live in the box. It's a recorded case by the group of Professor Zaman in Newcastle. So please, if you want to present a case, this is a case with the new Prevail drug-coated balloon from Medtronic. So stay there and don't miss this very nice case performed last week.
Right, thank you. If we could have the video case, please. I'll just do the quick introduction of the case. Thank you. Yes, next slide. So this is about a patient with in-stent restenosis that presents several years after the initial stent. And it will show a case where we debated about whether to use a drug-eluting stent or drug-coated balloon. 65 years old with non-insulin requiring type 2 diabetes mellitus. He's on statins, but has mild intolerance after a re-challenge. He underwent PCI to the proximal LAD with a bare metal stent in 2001. I remember 2 years before we had access to Cypher. These are all his medication. He had an inferior MI a couple of weeks ago and was placed on Procedural, and then he's on standard secondary prevention with oral treatment for his type 2 diabetes. I'm going to let the film run. Right, there's commentary on the film.
So, Dr. Al-Khalil, if you could just tell us what the strategy is for dealing with ISR.
Yeah, so as my colleague referred to, so this patient is scheduled for stage PCI as part of his complete revasc. The picture that were obtained during his inferior STEMI showed that there is a significant in-stent restenosis in a previously stented segment in the proximal LAD from 20 years ago. In my book, it is mandatory for these cases to do intravascular imaging, whether you do it with optical coherent tomography or intravascular ultrasound.
Yeah.
I think it is important to understand the mechanism of the stent failure.
In terms of the mechanism, do you want to just talk us through what the mechanisms of in-stent restenosis are?
Yeah, there are different ways of categorizing the mechanism, but broadly you could say there's a mechanical and a biological stent failure.
Dr. Farag, the guidelines also say that imaging is essential, and we're going to use that. So do you have any preference for IVUS versus OCT, or do you think both are interchangeable?
Well, I think both modalities are interchangeable. Perhaps I have got a lean towards OCT in very long diffuse disease like this, or where I want to get a better resolution of the stent and the filling mechanism. But both are used interchangeably.
So we're going to go to live view, and now we're going to see the pictures within the artery. Obviously, you can't tell what's going on. That's because of the blood. So nice image. We're going to take the OCT catheter out, and we're going to have a look in more detail about what's going on there. So the contrast clear was suboptimal distally, but we hope to see the mechanism when we come to the stent.
I think it's very tight. That's why the contrast is not reaching his
distal vessel.
Yeah. Distal vessel is
exactly.
very tight.
Yeah. So I'm just going to take this OCT catheter out, and we'll have a look at this.
Should have the stent coming shortly. And
yeah,
there we go.
Yeah, that's the stent. Well, it's a late stent failure. Basically, it's a mixture actually of an undersized stent and biological element, which compromised from both new atherosclerosis and new intimal hyperplasia.
Yes. So then to summarize, we believe this is a mixture of new intimal hyperplasia and new atherosclerosis.
Yeah.
It's a 20-year-old stent. There's a class 1A indication for drug-eluting stent and a DCB.
Yeah.
But because of the extent of new intimal hyperplasia, we're going to go with a strategy of a drug-eluting stent.
That's correct.
This is a 2.5 by 15 NC
even that
balloon.
is blocking the lumen.
So that's occlusive. So we're going just to 5 NC here.
I think given the OCT images that we've seen, it's very unlikely this will go behind the struts.
Yeah, exactly.
12, 14, 16, and down.
Okay.
So this is a 3 by 15 Prevail drug-coated balloon.
Okay, and slide nicely.
What was the deliverability like, Dr. Alcalil?
It's very good. Actually, I didn't say. That's all right. We could go here. Yeah, and we'll go up to nominal, and we'll leave it up for 1 minute. Just floor. Yeah, just floor. Okay, store that.
Good. Okay.
Yeah, that's good. Store that. So we don't have concern about the expansion of the balloon. We're going to use a 3/0 cutting balloon now for the area within the stent. So we're going to put a stent, and we try to put a stent in the mid-LAD distal to the diagonal, and then we're going to overlap that with another stent to come all the way back to the ostial of the LAD.
So nominal here is 12 atmospheres. So you have the option of using the balloon markers here to measure the length of the stent up to the ostium.
Yeah, so we're going to do that actually. So we're going to use the stent balloon for the overlap. We're going up. So the circosteum is not compromised. We could see the diagonal. So we go to the cranial, please.
So the distal LED does not really have flow.
Yes, I think let's finish with the OCT.
Go.
Looks lovely.
It might be useful now to decide whether the proximal side of the vessel you could go with a 4/0 actually and see.
Yeah.
Right.
Yeah.
So that might be an option.
So I think it would be also useful to see what the stent within a stent,
Yeah.
how the
Absolutely.
neointimal hyperplasia neoatheroma looks.
I think we may struggle just to clear the blood, but I think it's certainly worth trying. Go for it. And start full back. Ah, it's a nice picture. Now you can see the vessel properly after. So I'm just going to take this OCT out.
Here we go. Okay, just stop. Go slowly there. So there we can see the 2 layers of stents go back. Yeah. And we can see the neointimal hyperplasia that has been crushed between the 2 stents and expansion of the original stent.
The stent's slightly underexpanded here, which I think we probably should go back and post-slide this. Yeah. If you just keep going, Dave, yeah.
The stent in stent, I think he needs a little bit of
exactly.
Yeah.
Take a forward 12.
Yeah.
1, 2, 3, 4. It's probably a 4/0 vessel at that point.
Oh,
and
we could do some measurements actually. Keep going,
yeah.
and
here is you landing beautifully.
I think it's worth repeating that OCT. It gives us more information about what we need to do.
Oh, that's beautiful within the stent.
Okay, so I'll just fit in because it may not have been clear to people. So that this was both a proximal in-stent LAD in-stent restenosis case and also a bifurcation case in the LAD in the diagonal, a large first diagonal. So the Prevail drug-coated balloon was used to inflate and prepare and deal with the diagonal, which was a 3.5 millimeter Prevail balloon, and you saw a fantastic result. Now, I know Bruno will disagree with this, but the option of using either a DCB or DES in the in-stent restenosis and the LAD was discussed. And because there was de novo lesion extending up to the ostium of the LAD, proximal to the stent, the decision was made to use a stent from the ostial LAD to just distal to the in-stent restenosis.
Good. I think it's a very nice demonstration of imaging showing that this very late, 20 years late, in-stent restenosis was not caused by a mechanical issue, because this happens much earlier. If you have underexpanded stents, you will have stent thrombosis or more aggressive in-stent restenosis in a shorter period of time. This is basically neo-intimal hyperplasia and neoatherosclerosis at a very long time period. You showed very well with OCT. Of course, we can debate whether this needed a stent, or if you could manage both the bifurcation and the stent only with DCB. Bruno, what would have been your approach to this case?
We started to discuss what about de novo disease and what is the size we can treat for de novo disease. And I fully understand the argument of Asfar that he treated de novo disease in the proximal LAD. If you're not willing to do this, I fully understand that you use the stent approach. My approach is, as said before, a little bit different. I'm doing aggressive lesion prep, high pressure balloon inflation, at least 1-to-1, sometimes a little bit oversizing, and then decide what is the result. And then sometimes I end up with relevant dissections, then I have to stent it. But if not, I do avoid to implant new metal and use the DCB but then with 1-to-1 and only nominal pressure to not create new injury in this situation.
Yeah.
Okay.
I think that's a great point. Yeah.
Mm-hmm.
What I would just add to that, Bruno, is I think with your extensive experience, I think you're much more confident. I think we've used DCBs in ISR and mid to distal vessels and largely small vessels. And I think using it in the ostial LAD, proximate LAD, we do need more data. And on balance, I said to you that we had de novo lesion proximal to the stent, and this is the reason we used a drug-eluting stent for this particular case in the LAD. But I said we got a fantastic result with the Prevail DCB in the diagonal.
Great. Guys, there are really amazing number of questions. I would dedicate this last 7.5 minutes to go back to our colleagues, because it seems to be a lot of interest in that. So, very easy question, if it is. What to do if a drug coating balloon causes dissection? Bruno.
Yeah, then you have to stent. No way, and you choose a limus eluting stent for this purpose, not a bimetal stent, and try to use it as short as possible.
Which
Bruno,
is your
is there a way should we define that dissection? Because there's very good evidence that if the dissection is type A to type C, we can leave that alone. And once again, I think it's a experience thing. If it's DEF, flow limiting spiral, then I think we should use a stent.
Very important point, as far. I have a very high threshold to put a stent. I do trust on all balloon PCI. If the flow is good, the SCG is good. I mean, this is what you try to avoid. It's stenting. So which is your percentage of stenting after DCB, Bruno?
It's a really rare event. We are in the range clearly below 5%. If you do the lesion preparation as you have to do lesion preparation aggressive, because then you identify the lesions that require stent.
Good question. When you do a side branch in a bifurcation, do you use kissing with 2 DCB or not?
No, never. You should not do this. Number one, DCB lose drug in blood. The longer they stay in blood, the more drug you lose. And you have first, if you do kissing, you have to park the first one before you get in the second one. And then the first one will lose too much drug. And number two, you need contact of the DCB with the wall. If you have 2 balloons like this, you have huge areas where there is no contact of the balloon with the wall.
So you rather do DCB on one branch and then on the other?
Right. And if you have to do kissing, do it at the end of the procedure with plain balloons.
Okay. And I think that question also raises a bugbear of mine, that people equate a plain old balloon with a drug-coated balloon. I keep saying that if you want a mechanical result, use an ordinary balloon. If you want to deliver a drug, use a drug-coated balloon. And people have to get out of this idea that a drug-coated balloon achieves mechanical results, or they should try to achieve a mechanical result. And I think that's the point that Bruno is making, and that's the point I always make. A drug-coated balloon is only for drug delivery. If you want to kiss with proper angioplasty balloons.
As far Federico is asking if this procedure has any kind of specific risk.
Which procedure? Using a kissing balloon?
If DCB has any kind of risk which belongs to this technique.
I don't think so. The amount of drug that's in the systemic circulation is so small. Paclitaxel is rapidly absorbed into the intimal surface. So we now have years and years of experience. Bruno has done this for much longer. There is no systemic risk to the patient.
Bruno, Federico asked, can we use a DCB after a shockwave balloon?
Yes, you can. We did this already, and it looks very nice because this is a fantastic combination.
So no stent, just breaking the calcium, antiproliferative with paclitaxel or sirolimus, and leave it as it is. Great. Asman, when you decide to implant a second stent within a restenotic one, how you size it? That's a simple one.
Yeah, very simple. Imaging.
Intravascular imaging.
Intravascular imaging, correct. Yeah.
Okay. So, well, there are so many. It's difficult to pick the best. Can we use DCB? This is Sayan. Can we use DCB for treating ostial stenosis? I imagine should be probably the right coronary ostium. Or would you prefer in this case to put a stent?
Yeah, aorto-ostial disease requires stenting.
Good.
I'm glad you said that, Bruno. I thought, yeah.
I do agree. This is, most of the time, it's an aortic disease. Now you need robust support.
And I think the pathophysiology of the aorto-ostial region is different to the rest of the coronary arteries.
Okay, so we have 2 minutes to go, and there is no need to make conclusion, just very, very strong comments. I took notes from your lectures. Use as short as possible stents, so you are not keen on metallizing everything. Of course, trying to stay in the healthy part of the vessel. As large as possible. This goes with the best vessel preparation you can obtain before implanting the stent. Avoid 2 stents in bifurcation. This is, of course, an old advice. We can use drug-eluting balloons in bifurcations, but not kissing. One in the side branch and then one at the time. DCB as the first approach to avoid vessel shrinkage, especially in small vessels. So you have in the future an option to treat with stents if DCB fails. But from the studies you have shown, the efficacy and the safety of the two alternatives are very similar, I would say identical, and perhaps in favor of DCB. DCB is safe regardless of the type of drug, of the drug-eluting stents. So we are talking about paclitaxel-eluting balloons. And DCB can be used after dedicated calcium devices like IVL or ROTA. This is what we had to share with you, my colleagues. I hope this has been useful. There is a lot of interest in the chat, so we are happy that you like our comments. The last 10 seconds to say goodbye from Verona and to Bruno and Asfar. Thank you very much for staying with us.
Thank you.
Thank you.